So the topic of my podcast today is diabetes. I've chosen to divide my podcast into three separate parts. The first part relates to the pathophysiology of diabetes, including the medical management. The second part relates to complications of diabetes, primarily those that would be involved in managing a patient in ICU. And the third part relates to the anesthetic management of patients with diabetes. So everybody knows that patients with diabetes are at an increased risk for certain diseases like end-stage renal disease and macrovascular disease that leads to an increased need for vascular surgery, often culminating in lower extremity amputations. Cardiovascular disease is well known as well. But the question is, how many of you were aware of the fact that the surgical mortality rate for a diabetic patient is approximately 5 times that of a patient without diabetes? Currently, diabetes is classified as being either type 1 or type 2 diabetes. Historically, it was initially classified as adult onset or juvenile onset diabetes, was then classified as insulin dependent or a non-insulin dependent diabetes, but this classification is the one that is currently in vogue. Type 1 diabetes accounts for 5 to 10% of all cases of diabetes. It's usually diagnosed before 40 years of age, and it is one of the most common childhood illnesses. The incidence of type 1 diabetes is increasing by about 3 to 5% annually. Type 1 diabetes is caused by T-cell mediated destruction of the beta cells of the pancreas. At least 80 to 90% of the islet cell function must be lost before hyperglycemia occurs. Despite the fact that there's generally a preclinical period of 10 years or more, the initial presentation of type 1 diabetes is often sudden. A child will present with fatigue, polyuria, polydipsia, and manifestations of hypovolemia. If the initial presentation is one of ketoacidosis, it's indicative of a more severe insulin deficiency as well as lipolysis. Complete destruction of beta cells occurs within about 3 years of diagnosis in most children, although the process takes longer in adults. Type 2 diabetes is characterized by insulin resistance and relative beta cell insufficiency. An initial insensitivity to insulin by the peripheral tissues leads to hyperglycemia. The hyperglycemia in turn triggers an increase in insulin secretion in an attempt to maintain normal levels of blood glucose. The pancreatic function decreases, and eventually the pancreas is unable to compensate for the increased insulin resistance, and hyperglycemia occurs. Another element of type 2 diabetes is that there's also increased glucose production by the liver. The insulin resistance is an inherited component of type 2 diabetes, but obesity and a sedentary lifestyle are acquired contributing factors. Obese patients develop a compensatory hyperinsulinemia in an attempt to maintain normal glycemia. The increased insulin levels may result in desensitization of the peripheral tissues. There is also an increasing prevalence of type 2 diabetes, and that in children is related almost exclusively to obesity. We're not going to talk about gestational diabetes, but we will at least briefly mention a couple of other classifications of diabetes. They can be loosely aggregated into impaired beta cell function, defective action of insulin, an immune-mediated component, that caused by infection, or by pancreatic disease. So, drug-induced types of diabetes are associated with the agents listed here. Some of them, such as glucocorticoids, are absolutely straightforward. Others beta adrenergic agonists are not as self-evident. When you think about endocrine disease, everybody generally thinks of acromegaly and Cushing's syndrome, but the question again becomes how many people think of pheochromocytoma being associated with diabetes. These are the diagnostic criteria for diabetes as published by the American Diabetes Association. While hemoglobin A1C is not part of the diagnostic criteria, it is an important test. What happens is, because the hemoglobin is glycosylated by glucose, the percentage of hemoglobin molecules which are glycosylated is proportional to the average glucose concentration over the preceding 60 to 90 days. The normal range for hemoglobin A1C is 4 to 6%. If it's greater than 6.5%, there is an increased risk of both microvascular and macrovascular disease. Metabolic syndrome is getting a lot of publicity lately. I have to tell you that this picture was probably taken with a wide-angle lens. The reason I say that is that that type of lens makes objects that are closer to the camera, like the man's belly, appear disproportionately large. On the other hand, who am I to say? Maybe the guy really looks like that. I would almost expect this to be a topic of an in-training exam or a board exam question, and that would relate to the diagnostic criteria for metabolic syndrome. Metabolic syndrome is actually a constellation of clinical and biochemical findings that are frequently seen in patients with type 2 diabetes or for patients who are at risk for developing type 2 diabetes. Effectively, it combines insulin resistance, hypertension, a procoagulant state, obesity, and premature atherosclerosis, and those things work to place the patient at an increased risk of cardiovascular disease. It's been estimated that 25% of the adult population in the United States has metabolic syndrome. In talking about patients with type 2 diabetes, the first recommendation for therapy is generally weight loss. One of the things that's achieved with weight loss is that the decrease in adiposity improves insulin sensitivity and may actually increase insulin secretion. If that doesn't work, oral antidiabetic drugs are the next line of defense. These drugs can generally be classified as one of 4 types. The secretagogues, such as the sulfonylureas, the biguanides, metformin, we'll talk about that specifically for its anesthetic implications. Not even going to try to say the next word. And then the 4th classification is the alpha glucosidase inhibitors. The sulfonylureas stimulate insulin secretion. The 2nd generation drugs like glyburide and glipizide are more potent and have fewer side effects. However, because of the natural history of type 2 diabetes, they're not effective indefinitely. There's an issue of the potential for deleterious cardiac effects by this classification of drugs. That really hasn't been resolved. What we do know is that potassium ATP channels mediate ischemic preconditioning of the myocardium. This preconditioning provides myocardial protection and limits the size of an infarct. Sulfonylureas may inhibit the preconditioning. This can result not only in a larger area of myocardial infarction, but may also be associated with a delayed recovery of contractile function in ischemic myocardium. Metformin is currently the classic example of a biguanide. In addition to lowering blood glucose, biguanides also decrease plasma triglycerides and low-density lipoprotein cholesterol. The problem with biguanides is that there's an increased risk of lactic acidosis. This is a question that frequently appears in one way, shape, or form or the other on the in-training and board exam. It should be noted that there's an increased risk of metabolic acidosis in patients who have renal insufficiency. These drugs decrease insulin resistance by binding to receptors in skeletal muscle and adipose tissue. In addition to lowering blood sugar, they may also influence the dyslipidemia associated with diabetes. And finally, the alpha glucosidase inhibitors delay absorption of glucose from the intestine. They're administered immediately before a meal. Ultimately, for most patients with type 2 diabetes, oral anti-diabetic drug therapy becomes a combination therapy. It's generally initiated with a sulfonylurea or a biguanide, but as the patients become resistant to these drugs, they have other drugs with different mechanisms of action added. Eventually, if oral anti-diabetic therapy is not effective, the next step is usually a bedtime dose of intermediate formulation of insulin like NPH. The reason that the dose is usually given at nighttime is because hepatic overproduction of glucose is highest at night. Again, in patients with type 2 diabetes, tight control is defined as a hemoglobin A1C of less than 7% and low density lipoprotein level of less than 100 milligrams per deciliter. So insulin. Insulin is required in all patients with type 1 diabetes, and it's required in 30% of patients with type 2 diabetes. The rapid-acting and short-acting forms are used to provide glycemic control at mealtimes. The intermediate formulations are generally administered twice daily, while the long-acting forms are administered once a day. Hypoglycemia is the most common and most dangerous complication of insulin therapy. When administered in conjunction with insulin, these drugs, or alcohol, increase the risk that the patient will develop hypoglycemia. Notice that angiotensin-converting enzyme inhibitors and non-selective beta blockers are included on this list. One of the problems that occurs is something known as hypoglycemia unawareness. It's a condition in which the patient does not respond with the appropriate autonomic warning symptoms before neuroglycopenia occurs. Hypoglycemia unawareness is associated with repetitive episodes of hypoglycemia, especially those occurring at night. Hypoglycemia itself presents with symptoms of sweating, tachycardia, palpitations, restlessness, and pallor, whereas the neuroglycopenia presents with fatigue, confusion, headache, somnolence, eventually leading to convulsions or coma. The diagnosis of hypoglycemia is based on a plasma glucose of less than 50 milligrams per deciliter. That concludes the section on the basic pathophysiology of diabetes. The second section on complications of diabetes will be a completely different podcast. Thank you very much.